meeting. So we have the fellows, the new and the seniors. Welcome. And I want just to start with thank you to all of you. And I'd like to thank the team who is working to present today. So we have that. Make sure we are on the same page. We're still working on getting the teams with their team leaders connected. So hopefully this will be set up. Everyone will have the team ready and the team leader. If you didn't hear from the team leader, let me know. So this is just organizational for the continuity of this program. The second part is the project-based part. So some of you are already involved in some research work, which is great, but others are not involved yet. So we will get you involved in some of the research that are going on, and some of the project research leaders or managers will start forming their teams as well. So in the coming weeks, hopefully we will have some projects are running, and you can get involved in as many as you would like if you have time. And we understand some of you might be busy preparing for some tests like step 2 or step 3. So if you are busy, we understand, but at least we want you to get involved in one project in the coming year. Hopefully you will benefit from this program. Thank you. And at this time, I will hand it to Dr. Mahir and Dr. Lipi to start the presentation. Thank you so much.
Thank you, Dr. Nadir. We have our presenter, Dr. Ibrahim. He will present the urinary continence. Dr. Ibrahim, are you ready?
Hi, Samahir. Yes, I'm ready.
Thank you.
Dr. Ibrahim, I'll give you the host. So now you can share your screen.
Okay, let me try, Dr. Nadir, so you can share it from here if it's possible. Yeah, I have some problems sharing my screen, so if you can share it, it would be great.
Okay, give me a second.
Okay.
So I'm gonna share the screen and you can let me know.
Because you disabled the attendee, so if can enable me, I can also share from here.
You can share your screen or
Yeah, because it says like the host disabled attendee screen sharing. So
okay, now try again.
okay,
Can you share the screen or you still having
no,
problem?
no, 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 I can. Yeah, I can't. I can't. So I can proceed with your screen sharing. So we can like
Okay.
start the presentation with screen from that you have.
So let me know when you want me to. You can see the screen now, right?
Yeah, I can see, but I don't know if you can make it a bit bigger or that's the maximum.
Can you see the screen now?
Yeah, yeah, it's okay. That's good.
All right.
Um, can you hear me well? I mean, like, I don't know if my voice is clear or not.
It's clear. Thank you.
Okay, thank you, Dr. Nadir. Thank you, the panel. Thank you, uh, our colleagues. Uh, my name is Ibrahim Adam Usman. I'm graduate from Al Fashir University, Sudan, 2018. I've done with USMLE Step 1, Step 2, and hopefully I will be an applicant in the upcoming match season. So I'm happy today to present the topic of urinary symptoms in the older adults with a special focus on evaluation and management of urinary incontinence. So the next screen, next slide, I mean. Yeah, okay. Starting with definition of incontinence. This is very important. The involuntary loss of enough urine to cause social and hygienic problem. And the last line is very important because when we talk about just leakage of urine, then we may end up with a problem with the global problems that would be similar to the global warming. So the last line, social and hygienic problem, is very important. Reported prevalence rate of urinary incontinence vary depending on so many factors, including population studied, definition of urinary incontinence, and how information is obtained. Starting with population studied, as we know, like uh, countries with high elderly rates definitely would have higher rates, and others like developing countries uh, with expanding population have like smaller numbers of elderly people. So the rates and prevalence of urinary incontinence would be for sure, lesser than those of the expanding, like stationary pyramids, and we will see this in the next slide. But the definition of urinary incontinence, as we have mentioned, also is important because if we include any case with leaking urine, it will be also a bigger problem. So restricting the definition with the social and hygienic problem makes the prevalence a bit different. And how the information is obtained also important because this issue is somewhat embarrassing. So it may be subjected to reporting bias. So yeah, next slide. Here's the population pyramids as we see here in the far left, as we can see, is expanding population. And the people at the age of 60 to 64 are very few compared to the other two pyramids like contracting and stationary pyramids. And contracting pyramids like in Germany and stationary in the United States, they have so many people above 65 and 60 years because of good health care, good income, and also the health system that treat a lot of chronic conditions, making people to live longer. The next slide, please. Okay. Here are some statistics like the urinary incontinence affects 38 to 35% or 55% of women above 60 and 50 to 84 of elderly in long-term care facilities. At any age, female to male ratio is like 2 to 1. So it is as common in female, as twice as common in female than in male. Here we have a case scenario from Ms. Jones. A 76-year-old woman confides in you that she has problems controlling her urine. She reports that she stays close to home and always knows where the bathrooms are. She had she has had intermittent urinary incontinence. Urine loss is precipitated by rushing, running water, and hand washing. Sometimes she loses urine when she coughs, sneezes, and laughs. She now wears pads daily. She is concerned that the problem is more frequent and interfering significantly with her daily golf game. So we need to keep this in mind while navigating through the other slides up to the end of this presentation, because we will answer some questions about this case. So requirements for continence, mentation, motivation, mobility, manual dexterity, and proper lower urinary tract function. First one, like mental state is important. So like people who have some kind of decreased consciousness or something like this have problems controlling their urine, and also motivation to control that is important. So mobility is also important, as we will see in the next slide. So also manual dexterity, as you know, the micturition is a skill demanding process. So people having problems like stroke and something like this also will find some problems controlling their continence. And also poor lower urinary tract function. Mm, uh, proper lower urinary tract function is also a very important factor in controlling urine and maintaining continence. Next slide. Okay. Here are normal changes which predispose the elderly to incontinence. As we have mentioned, that it is common in the elderly, and with age, some changes that predispose to this health problem. Some increase bladder capacity, inability or inhibitory ability, also decreased bladder capacity, decreased inhibitory ability, and decreased urethral closing pressure. All this also predisposed to urinary incontinence in elderly. Other increased factors that also predispose to this was are like residual volume and inhibited detrusor contractions. These factors are age related and predispose to urinary incontinence in elderly. But very important, incontinence is not a normal part of aging. So this would not be confused with the past. I mean, the last slide. As we said, aging brings some factors that precipitate to urinary incontinence. However, urinary incontinence itself is not a normal part of aging. Next. So when we are assessing any patient with urinary incontinence, we need to decide some points. Like decision point one, what contributors are present, and at this level, we will decide or determine it is transient, like reversible, or established, like chronic. I mean, so at this level, we need to differentiate between two, and we'll see in the next slide also the types of incontinence and which are reversible and which are uh, established and chronic. Here are transient incontinence causes like drugs, restricted mobility, infection, polyuria, and you can abbreviate them in drip. At the other side, in the right side, you can see dietary, I mean, retention of feces, inflammation, and psychological factors. All these are reversible, causes. However, these patients have normal lower urinary tract, and that's why all these factors have, like mentioned factors, can be reversed easily, unlike the coming one. Uh, Here are some details about also reversible conditions. We mentioned drugs, and here are some drugs like drugs that cause decreased storage, like sympathetic blockers, alpha or beta, and also cholinergic agents, diuretics, caffeine, ethanol, artificial sweeteners, and more. Also, other factors like which increases urinary retention, alpha agonists, beta agonists, anticholinergic agents, calcium channel blockers, and narcotics. These factors, these drugs, all these drugs can cause urinary incontinence. However, you may notice that at the right side, these agents increase retention. However, as we will see in the obstructive incontinence and overflow incontinence, we have retention, then incontinence at the same time. So, not to confuse that, we are saying contradictory factors. Like, what diagnostic tests would be performed, and uh, in the process of our in the journey of our diagnosis and management of patients with urinary incontinence. Per agency for healthcare policy and research guidelines, history and physical examination, as any case in medicine. Then these are general, and then some specific, just like voiding diary, urinalysis, and post-void residual. These are specific to diagnose and to differentiate which type of urinary incontinence that we have. Voiding diary purpose. This is to assess the severity of the case, severity of the condition, and determine the precipitating events, and identify fluid intake patterns, identify voiding patterns. And this measured over 3 days and gives a lot of information about the condition and may help reach the diagnosis. Okay, we had the voiding diary sample, but I can't share it from here. I don't know if it is available. Then we can just put it uh, in the website. So, and everyone can just search and look at samples for voiding diary, and that the different types of uh, urinary incontinence have different patterns of voiding diary. So just search for it and you will find. Back to Miss Jones' voiding diary, we found that voiding interval is short and leakage episodes frequent. Part use, yes, daily. Food and fluids, normal. Activity, significant restriction. Keep in mind these findings and we will see the diagnosis later. Okay, after differentiating between is it reversible or established, at the second point, what type of established urinary incontinence, if it is established? We have been talking about the reversible, like drugs and infections and others, and now we have to talk about the established chronic types of urinary incontinence, functional, abnormal urinary tract. Functional is something not related to urinary tract, like some mobility problems and so on. And here back in the next, slide, we will find some details about that. But abnormal lower urinary tract, in fact, urinary tract is also the most important type of urinary incontinence. Next slide, please. Yeah, here we have lower urinary tract impairment of function. And as you see, we have two by two table. So we have storage problems and release problems. And at the y-axis, we have bladder and urethra. So yeah, as you see, if we have a storage problem and a problem in the bladder, it will cause urge incontinence. If the problem is in the urethra, then it will cause stress incontinence. If you have problem with release and bladder can't release urine, then it is overflow incontinence. And if the urethra is dysfunctioning and it can't release the urine properly, then it's obstructive incontinence. Those are important four types. And sometimes people join the left two, overflow and obstructive, in the same category. Uh, Here we have post-voiding residual. So in the left side, we have 0 to 100 ml, and this is normal. So we have no increased post-voiding volume in the urge incontinence as well as in the stress incontinence. Unlike in the right side, we have release problems, so overflow and obstructive have higher voiding residual. So next slide, the illustration of
Okay. Can you explain the PVR, the post-voidal residual, what how they do it?
please.
Okay.
Okay, here we have the in the left we have overflow. As you see, the bladder is full, but we have some contraction problems. So urine is leaking due to pressure difference between the bladder and the urethra. In the stress, as we see, the force from the abdomen pressing over the bladder and making incontinence. In the urge incontinence, there's some kind of irritation in the bladder, and it contracts and randomly and frequently, and causing leakage of urine and urge to urinate. So urge incontinence, also known as detrusor instability, detrusor hyperactivity, detrusor overactivity. All these are the names for the same condition. Most common etiology, frequent voiding of, most common etiology here not mentioned, but UTI is one of the commonest causes of urge incontinence. And you may have seen a lot of people like this. So frequent voiding of moderate amount, problem occur day and night, but they have normal post-voiding residual. So, concerning the stress incontinence, leakage of a small amount of urine with increased abdominal pressure, dry at night, because really less factors, I mean, fewer factors that can cause increasing intra-abdominal pressure at night. So they have no problems maintaining the dryness at night, and also they have normal post-voidal residual. Neurogenic overflow incontinence, also known as myopathic incontinence, detrusor contraction weakened by muscular or neurologic disease, frequent loss of small to moderate amounts, occur day and night also. Increased, in this case, we have increased post-voidal residual. Obstructive overflow incontinence, as I have said in the previous slides, these are sometimes separate, obstructive and overflow, but sometimes they are combined into one because the mechanism is the same. Elimination, elimination incomplete from urethral blockage. Sometimes urethral and sometimes because of bladder, as we have said, inability to contract. Primarily men with prostate disease frequently loss of small to moderate amounts occur day and night, and also they have increased post-voidal residual. Back to Ms. Jones, what type of urinary incontinence does she appear to have? Uh, just you can type the answer in the chat box and we will see the diagnosis at the end of the presentation. Here's another case. Mr. IP a lot is a 72-year-old man who complains of 1 month history of progressive difficulty initiating urination, weak stream, incomplete emptying, frequency, urgency, and abdominal discomfort. Uh, he leaks small amount of urine frequently. This is like straightforward, and you may know the diagnosis from the scenario. So also type for Mr. IP a lot. You answer. Mr. IP a lot has history of hypertension, benign prostatic hypertrophy. This medication include metoprolol and in Elavil 25 milligram, Tylenol 650 milligram. We have here tricyclic antidepressant, beta blocker, and analgesic. So these medications have significance in diagnosis of the case in the case of reversible urinary incontinence because tricyclic antidepressant has their anticholinergic effect in the urinary tract. Here's another case, also 67-year-old man with history of hypertension, benign prostatic hyperplasia, prostate cancer, treated with radical prostatectomy, reports small volume urinary incontinence, interferes with his work as handyman. Keep in mind also this case and its diagnosis. Back to Ms. Jones. What type of urinary incontinence does she appears to have? The answer is urge incontinence. I hope you answered the same. Um, because it was like mixed information about stress and urge incontinence. If we can go back to that, to the scenario, Dr. Nadir, if possible, the scenario for, yeah, here. Just look at this, and we have here like intermittent urinary incontinence, urine loss precipitated by rushing, running water. In this situation, running water and hand washing resemble the normal micturition situation. So as you know, like if you saw someone to drinking water, you will feel thirsty, and someone yawning, you will feel sleepy. Exactly the same occurs with micturition. Also, here we have sometimes she loses urine when she coughs, sneezes, and laugh, and this goes with stress incontinence. And the case here is that some factors that increase intra-abdominal pressure precipitate the, I mean, existing urge incontinence. That's why it's mentioned here, but the diagnosis is urge incontinence. If you have another opinion about this also, I will be happy to hear in the chat box. So here's the answer is urge incontinence. The next, what therapists would you recommend? So the next slide is about the treatment. Decision point 3, what type of management? We know we have knew the diagnosis, and uh, now we are treating. And we have 3 modalities of treatment: behavioral, pharmacological, or surgical. Per AHCPR guidelines, start with behavioral or pharmacological first. And sorry, I mean pharmacological approach. Then patient preference, motivation must be discussed. The slide is like not visible completely. I don't know the issue. Yeah, but the point is that we need to discuss with patient which option of treatment we choose and to explain to the patient why is that, and that's all. The next slide. Uh, Here we have bladder training. Requires the patient to resist or inhibit sensation of urgency, postpone voiding, and urinate according to timetable. Like as we have said, like discussing with the patient is important in such a kind of treatment because as you see, it is completely done by the patient. So if you don't talk to the patient properly and teach him how to, or her, how to do this one, and then the whole journey could fail. So bladder training, as we said, requires the patient collaboration with the doctor to carry it like properly. The next slide. Another behavioral modality to treat the urinary incontinence, pelvic muscle rehabilitation. Pelvic muscle exercise, active exercise to increase periurethral muscle strength, and this is like recommended with stress incontinence. As we know, weakness of pelvic muscles, the increased mobility of urethra, and malfunctioning of it, and so it predisposes to urinary incontinence. Biofeedback, and this is mainly diagnostic rather than therapeutic, use of electronic or mechanical instrument to display information about neuromuscular and bladder activity. We have some pharmacological treatments and commonly used in urge incontinence, anticholinergic agents. First line, mean darifenacin, oxybutynin, way down to trospium. So these are mainly the first line of treatment in the case of urge incontinence, and we have said that bladder training and other behavioral modalities are good for other types of incontinence like stress incontinence. Alternative management, supportive measures. Intermittent castration, substructive, indwelling urethral castration, again is obstructive, suprapubic catheters, external collection systems, penile compression devices, pelvic organ support, and absorbent pads or garments. So these are supportive. However, as you see, many of them have the common drawback of increasing the risk of urinary tract infection. So when would you consider referral to the specialist, to a specialist, the referring the case of urinary incontinence to a specialist? It's important to to do all the steps that we have mentioned, from history, from examination, voiding diary, and urine analysis, and residual study. So after that, we have certain conditions we need to see the specialist. Uncertain diagnosis, after all that we have done, we are uncertain about diagnosis, then we need to refer. Failure to respond to an adequate therapeutic trial, again, it's indication for referral. Hematuria without infection, again, it is indication to refer. Recurrent symptomatic UTIs, also indication, and abnormal post-voidal residual. All these factors are indication for referrals. Where can you get help? Of course, urology on top, gynecology, maybe geriatrics, physical therapy, clinical nurse specialist. But also we can find some help from neurologists, because some neurological problems also cause urinary incontinence, like normal pressure hypertension and so many others. So it is collaborative management of urinary incontinence. Deliver large amount of patient education, repeat information over time, and this is a very important point. And also, teach back method could benefit here when the patient explain to the physician what to do. Lead patient through a series of informed decisions about diagnostic and therapeutic options, why we are doing this, and what to do and why we are doing so. Patient be informed and actively participate in planning and executing the management plans of this condition. Provide self-management skills, also it's important, as we have mentioned about the pelvic exercise and bladder training. And professional tools, patient forms, patient education handout are available at gericareonline.net. So for doctors who seeking for this. So thank you for your attention, and I'm sorry for having some technical problems. And thank you so much, Dr. Nadir, for helping me doing this presentation. These are some references about the presentation from Medscape, presentation from Dr. Lisa, and other resources. So if you have any questions, I'd be happy to hear. But before that, I ask Dr. Nadir to give us some highlights about the whole topic, and also about the post-voidal residual, as he have asked me, but I've no really comprehensive idea about it. So it would be great if you could have or could give us some points in this point. Thank you very much.
Thank you so much, Dr. Ibrahim, for great, excellent presentation. So it's an important topic, and it's we can delve in more details, but the general idea is that as we get older, sometimes things might change, especially when we undergo some, like if you have a little bit of infection here, change in medication there, if you add all this together, the system might not handle it similar to the young population. But thank you, great presentation. So coming back to the question I asked about the PVR. So it's basically an ultrasound of the bladder. What you do is you ask the patient to void, and then you come and check the bladder volume. If it's 100 or less than that, that they emptied their bladder, and that's meaning the muscles and the volume of the bladder is under control. The patient can manage that by themselves. If, however, on the other side, you ask them to void and you come back and you do the ultrasound of the bladder and you find that the bladder volume is more than 100, let's say 2 or 300, 350, 500, something like that, that means the patient is not able to void. The muscles are not contracting. That's one problem. The other problem, the muscle of the sphincter where the urethra connect with the bladder is too tight. So either one of these or combination is going on, or there is some nerve problem. So the signal from the patient head or the brain is not going through to the bladder to contract and the urethra to open and empty the bladder. So that will give you an idea of what's going on. As you mentioned in the table, you do the ultrasound. If it's more than 100, that means there's problem with contracting, so that you can fix that, or the sphincter is very tight. If it's less than 100, that means there is problem when they are unable to control the urine, the incontinence. That means there is either stress or urge going on. So this how you use the PVR or post-voidal residual in a nutshell. Any other questions? So I'm gonna highlight one point. If you don't learn anything from this, the only one point I want you to learn in geriatric in general, medication can cause anything. And in these cases, a medication can contribute to the bladder problem. So it can cause either incontinence. So people may take some medication that cause them to be unable to control their urination or voiding. On the other side, also some medication may cause them to retain their urine, so they will be having trouble voiding. So it's urinary retention. So either or, the point you want to go home with is medication can cause problem in all the adults. So whenever you have history, you want to start with, or you want to answer, the first answer of every question in geriatric population is the medication. So we blame medication for everything. And not necessarily only in older patients, even younger people can have problems with medications as far as this topic. So I'm gonna share with you a personal story. A few years ago, I had a fall. I ended up falling on my arm, break my bone. So I went to the hospital and they offered me a surgery for repairing my arm, like just fixing open and reduction of my bone and so forth. So I underwent the surgery and I came out very good. So pain-wise, I was lucky. I didn't have pain after the surgery. But on the same day I was at the hospital for observation, I could not control myself, voiding. So it was very impressive. It was just a horrible feeling that you know you want to go, but you cannot hold it until you reach the bathroom, for example. When I went through that, the nurse was comforting me. It's like, oh, it's okay, it happened, and so forth. And when I realized at that time I was not able to control it because of the anesthesia still on my body. So the medications, either the pain medication or the anesthesia itself, can cause someone to be unable to communicate with the bladder, either to control or release. So the point, the second point I want to make sure you understand is the concept of the physiology of voiding. So we have the bladder, it's like a case, or it's like the storage area. And then the urethra, it's like the releasing, and there is a valve in the middle between them, which is the sphincter. Each one of them is controlled, and they're supposed to be in coordination. So if the bladder is contracting the muscles of the bladder, the urethra or the sphincter is supposed to release and open the urethra so the bladder can be emptied, so the flow can go outside of the bladder. This is supposed to be working in coordination. So whenever there is a need, then your bladder will contract, and then your sphincter will release or relax. That's when you are able to go like in the bathroom or something. But in certain situation, you are not able to. Let's say I was in the airport and I want to find the bathroom, but I'm really in the situation I need to go. So my body will try to relax the bladder and at the same time control the sphincter very hard so that I cannot drip or have accident. So this is the mechanism. It's just coordination between the two muscles. Whenever there is a problem, then you will end up of using, like if you have incontinence, most likely, as Dr. Ibrahim mentioned, these are the four possibilities. Sometimes it's obvious it's one of them. Sometimes it can be a combination. As we get older, sometimes this might happen. But thank you so much, Dr. Ibrahim. And any other comments or questions?
Dr. Nader, good evening.
Go ahead.
Since a lot of patients will end up with the Follis catheter, I have a suggestion that we can present something like, because they will come a lot to the emergency, especially with the UTI. So how to differentiate between catheter-associated UTI and the catheter-associated asymptomatic bacteriuria, and when to treat it. That's it.
That's a nice topic. I think it's a great one, and we can discuss this in the future. Thank you.
Thank you.
If no other comments or questions, we can move on.
Thank you, Dr. Nader. We have Dr. Ali, who's going to present. Dr. Ali, are you ready?
Okay, hello everyone. Is my voice clear? Just making sure.
Yes.
Okay, thank you. I need to give you. Okay, yep, now I can share this.
Okay. The photograph on each array on the A level and 3B level.
Just give me a second. Okay, you can all see my screen now.
Yes.
Okay, hello and good evening, everyone. My name is Ali Bashir, and I'll be presenting the basic of ethics in research today. So first of all, I'd like to give credit to Dr. Rebecca Dahl. I used some of her slides in helping making this presentation. Okay. To start the topic, let's say the ethical question is always at the core of my medical research due to the dynamic nature of research and involvement of multiple parties. So we have researchers, we have institutions, we have subjects, and sometimes the sponsors. So we're always faced by questions and ethical dilemmas that need to be solved. So the nature of the topic is wide and vast, but the goal of this presentation is to give you a glance at how have we reached the ethical principles we rely on today, and how do we address conflicts and our position in the current moment for research in the US. Okay, so again, multiple interests carry the risk of conflicts, and among these interests, the job of the researcher is to be aware and solve these conflicts. Hello, everyone, again. I'm not sure what happened. I guess we faced some technical difficulty. Uh, but I've lost the host settings now. Oh, okay. Thank you.
Sorry about that.
No worries. Thank you. Okay, so I was about to share a story with you that I've encountered working in some research. So in a food study, the subjects were complaining about the quality of food that they were getting, which led them eventually to start hoarding or storing food that they liked and not eating the food that they didn't like. So that would lead to inconsistency in the data because it's a food restricted study. So a good communication with the subjects and all parties involved would even lead to more accurate data that we are producing. Okay. So when faced by a question that requires decision making, we use two types of reasoning. One is the deductive or principle based reasoning, and the second is the inductive or case based reasoning. And I will elaborate that in more seconds. Okay. So even in law, the same rules go on. Okay, the deductive or principle-based reasoning starts with an ethical theory, continue with a specific principle, develop rules, and make judgments. So to make this more clear, let's say, for example, that a patient or a subject want to walk out of the study. So the ethical principle that we would use would be autonomy. Let's say all patients are autonomous. The rule would be that the patient have the right to have autonomy in leaving or being involved in the study. So the decision or the judgment would be patient is allowed to walk out of the study. The second type is the case-based reasoning, is decisions we have made in the past. So we look at these decisions, we combine them in order to make judgments, and they reflect back on the rules, and the rules reflect back on the principles. So it's a dynamic process. Both affect each other and both interact with each other. So let's say, for example, more in a historical view, imprisoned subjects like in Nuremberg, post-World War II, in Nazi Germany, the Nazi doctors had experiments on imprisoned subjects. So that led to today we have special considerations for imprisoned patients or subjects, and we have to treat them with more cautious interaction because there is a threat of coercion and their lack of autonomy. So it's a dynamic process, as we said, and we will get into that more in seconds. Okay, so same thing. Okay, sorry. Oh, okay, sorry. Okay, so in a busy world of research, scientists sometimes forget to consider what the research subjects want and how they see things. Because of this, the subject might not tell the truth and may try to hide things which will hurt the reliability of our study results. Okay, so we already mentioned the Nuremberg experiments. One of the most famous experiments here in the US is the Tuskegee experiments, or the study. The other name for it is the study of untreated syphilis in black males, which is like putting it more nice word than the original name, where subjects were left untreated after they were injected with syphilis to see the effects of syphilis and how to grow on. So also there's the penicillin rheumatic fever study where patients were not provided treatment. As you can see, all of this had led to later, now we don't like treat patients and left the control group with no treatments. We either treat them both or we give the control group the standard of treatment. So one of the earliest literature on this matter was the Beecher report, uh, which which its name was Ethics and Clinical Research. It was published in the New England Journal of Medicine. It was an alarming report about research practices that the researchers see as threatening for subjects in the US, and this led to get more attention toward protection of subjects in research in the US. So the federal government have established the National Research Act in 1974, which led to establish of the IRBs. So the IRBs that we today obtain for studies was established by the National Research Act. And the role of the institutional boards, in other words, to determine whether the rights and welfare of the subjects are adequately protected and whether the study adheres to sound ethical and scientific principles. So how do we implement this? So let's say that we have a study, we get the IRB approval, so we have the Office of Health, the Office, uh, sorry, so we have the Office of Human Research Protection, which will negotiate the IRB with the IRB and set forth how the study should go on. And we also have the FDA, which does the inspection and audits to make sure that the IRB and the study is implemented according to the way it should go. Okay. So the cornerstone of determining principles we use today is the Belmont report, which was published in the 1979. So the main cores of ethical research today are respect, to treat others in autonomous agents, allow people to choice, beneficence, which is act of kindness that beyond charity and duty, various obligations, i.e. do no harm, promote good, and justice, which is treat people fairly, and many principles stems from these three. Okay, so the conflict arises because with medical research or clinical research, to say the goal is to generate medical knowledge, i.e., not to treat patients directly, but it might come as a side effect, while the goal of clinical care is to treat patients. But nevertheless, we have to make sure that the subjects involved in the study do not get harmed and they get positively impacted by this research. Okay, so if we have a home to take message of this long journey of research, in the US, it would be the following points. One, a valid research design take into account relevant theory, methods, and prior findings. Two, competence of a researcher. You have to make sure that he is, or the researcher, capable to carry out the procedure. If Owen was involved in a research setting in the US, he would know that researchers or the people who they delegate their duties to have to take an enormous amount of courses, training, and procedures to conduct the research process. Identification of consequences, assessment of risk and benefits, which is maximizing the benefit and minimizing the risk as possible. And compensation for injury, responsibility for what happens to the subjects. So the federal law requires that the subjects be informed about compensation, but it doesn't require compensation. So if there is a compensation or not, it have to be set forth and tell them about the amount that they will get. Okay, so voluntary informed consent, which is one of the most important things, to be obtained before the study begins without undue threat or inducement, with enough information and agreement to participate. And the selection of subjects have to be appropriate to the purposes of the study, representative population that will benefit from the research and appropriate in number. So let's go back again for the principles. How do we derive practices from the principles that we already mentioned? Okay, so if the principle is respect for person, so that means each person has individual rights. The practice will be obtain informed consent and protect privacy and maintain confidentiality of this subject. If the principle is beneficence, the meaning would be provide benefit and protect from harm and limit the risk. So the practice will be assessment made standard procedure used to include all groups that may benefit. Okay. And justice would be equitable selection of the subjects that would be drawing from and would be benefiting from the research study. Okay, thank you. If you have any questions, I would be more than happy to discuss. Dr. Nader, your input is highly valuable if you have any additions. Thank you.
Thank you so much, Dr. Ali. This is also a great presentation. And basically, it's a summarize of what we should do as researcher. So in the recent few weeks, there are a couple of retraction of articles. When we look at them, we can see what's the problem. So Dr. Ali mentioned in the past they used certain method to obtain data or contribute to the literature, the knowledge, in the expense of the health of some human beings here in the US. So the IRB was formed to prevent this from happening. But also we want to make sure we are not only doing no harm, but we are honest as far as obtaining the data and presenting the data and sharing that with in articles or conferences. So make sure you are doing your best without influence, because some people might do some type of research just to get money from companies that promote or sell certain drugs. So we don't want to get into that business. So thank you so much, Dr. Ali. It's important topic, and in the future, we will go into some details as far as the IRB and the consent and so forth. But thank you so much. Any questions or comments? If not, we can move on to the next topic.
Hi, so the presenters from my group, the first presenter is Sayda Asna Munawar. If she's ready, we can start.
Hello, Dr. Lipi, can you hear me?
Yes.
All right. So I'll just try to share my screen first.
You can try it again, Dr. Sayda.
All right. So this is actually my first meeting, so I would like to introduce myself. I am Dr. Sayda Asna Shireen Munawar. You can call me Asna. I've graduated from Deccan College of Medical Sciences, India, and thereafter I've been working as a general practitioner. And due to my extensive experience in the intensive care unit, I was offered the position of being an instructor. So I'm currently working as an American Heart Association instructor in India, along with preparing for my USMLE steps. I also have the fortunate experience of working as a medical scribe for a board certified physician. So the topic that I'm presenting today is something that I use on a daily basis. So hopefully I can contribute to that. And saying all of that, I'm truly grateful to Dr. Nadir and his entire team for giving us all this wonderful platform for enhancing our skills in research. Thank you so much, sir.
You're welcome.
Yes, sir. So with that, I would like to start off with the presentation. So my topic for today is Google Documents. Basically, how do you create them? How do you share them? And basically make edits in it. So I'll proceed with it. I'll just give a brief, I'll just go through the slides and then give a practical demonstration. So the Google Documents are a word processing tool that allows us to create, edit, and collaborate on documents in real time. And it's a seamless and user-friendly experience, making it easy for individuals and teams to work together effectively. So the first thing about creating a Google document is firstly you start from the scratch. You open the Google Documents app and you choose the blank option to start a new document. Then you use a template, explore the template gallery to find a pre-designed template format that suits your needs, saving your time and effort. And then the next step is import existing files, easily import documents from your local device or cloud storage.
Excuse me, I think you should, yeah, okay, now it's okay, yeah. Because the page is not like what you're saying, just that was still in the first page. Thank you.
All right, all right. So the next thing is formatting and editing a Google document. Text formatting, customize. So basically, we can customize the document's appearance by adjusting the font styles, sizes, and colors. And you can also create heading, paragraphs, and lists. Layout and alignment, organize the content by adjusting the margins, the page orientation, and alignment options to achieve our desired layout as a team. And inserting elements, again, I think it's just like any other like a Word or a PowerPoint, where we can just add images, tables, charts, and even equations to express our ideas. And the next thing is how do we share a Google document with others? We share, either we can share the link directly, wherein we can create a shareable link and allow others to view or edit the document. The next step is we can also email that invite to specific people. And third step is we can manage the access, as in who can view, who can comment or edit the document. So again, continuing with that, we can grant editing rights in the sharing settings. I'll be showing you that in a minute. We can select candidate to allow others to make changes to the document, collaborate in real time. Multiple users can work on a document simultaneously and track revisions. Like we can keep a detailed history of all the changes that is going on. And the next thing is that we can also allow other people to comment on the document, wherein in the shared setting, we can choose to comment and allow others to provide the feedback. And we can have a threaded discussion in which there is like it is displayed as a conversation and making it easy for all of us to follow and move forward. Resolve comments. Document owners can resolve comments once they have been addressed. So whoever is the owner of the document, they can, once the issue has been resolved, they can remove it. And email notifications. Users can opt in to receive email notifications whenever new comments are added, ensuring that they stay informed. So we can see again, continuing with that, we can see the revisions that have been made. We can track all the changes. And we can accept or reject. As an owner, I can accept somebody's comment or I can reject it. That is my privilege as an owner. And third step is collaborate live. Multiple users can work on the same document simultaneously. So the conclusion and the key takeaways of this presentation is seamless collaboration that they enable real-time teamwork with multiple users to edit, comment, and track changes. Flexible sharing, we can easily share the documents with others. And robust features, the tool allows for a wide range of formatting, layout, and content enhancing options. So now I'll move forward with the practical demonstration. So as we all received a orientation email as research fellows from Dr. Nadir, so in the orientation email, there was a step 4 that had mentioned to create a Google document and add in our team leaders. So I'm going to use that and basically show you, especially for those who've joined new, so it can help you create this and add your team leader in it. So this is the email that Dr. Nadir had forwarded to all the new research fellows. So I'm going to read this. So create a template, log into your Google account and visit this website to create a new document and add the following headings: my presentations, my project, skills, and paper, and then share the document link with your team leader when you're done. So I'm going to copy paste this. Right. And I'm going to open this link. So since I'm already signed in, it has taken me directly to the Google Documents and...
sorry to interrupt. I think the screen is still set on the introduction to the Google Sheet. So can you unshare the screen and then share the screen where you want us to follow you? Because we're still on the PowerPoint presentation.
Just a second. So
if you can just stop the screen share and then share again why you want to follow.
is it visible now, sir?
Yes, thank you.
So this was the email that we all received. So I just copied this 5 bullet points and I've created a new, 1 second. So just open this link. Since I'm already signed in, it has taken me to a new document. Okay, so the first thing that I can do is I can change the name, right? So I want it to be specific because I have to add my team leader in it. So I'm going to put it as TGRF and put my name so that, you know, my team leader has it, it's easier for her to recognize that it's mine. And then I can just add in this, whatever I've copied from the email, and then just maybe add in a bit of space, right? And the next thing is that I can share it, right? So So I'm going to add my team leader over here. I'm going to add Dr. Lipi. Dr. Lipi, I'm aware that I've already made this document just for the purpose of demonstration. So I'm going to tick in the notify people, and I'm going to make her the editor so that she can update the document. I can also, if I'm like I do not want other people to make any changes in it, I can just make them as a viewer. Or if I want them to comment on the document that I've created, I can make them as a commenter. So currently I want her to be the editor. So I choose that, and then I can type in a message if I want to, and then send. There's also another way that I can copy this link and I can directly attach it to a mail. So I'm just going to send this to her. So what happens is the next step, she's going to receive an email notification that I have granted her the access. And now you can see that both of us are sharing the document, right? So the benefit of it is that once you start accepting it, I think one of the takeaway point of the Google Documents is, I think the most coolest feature of it is the real-time situation, wherein both of us can be active at the same time and both of us can be typing at the same time. For example, if Dr. Lipi was to be online right now, she would have been like the cursor would show my name, and so I can type what I want to, and she can type what she wants to, and both of us can collaborate at the same time without having I mean it's really cool to see that. And then now let's just move back to this. So next thing is I can start this document because this is important for me. I can you can see the document status that all the changes are saved to drive. Basically, everything that I'm going to do over here is going to be automatically saved, but just make sure that you check that it is always updated. And so next, moving on to file. So you can create a new one, you can open a new one, you can share it, you can, it's basically the same. Either you can use this option or this one. And then you can rename it. We've already done that. We can move it. Then the version history, I think this is very important actually. So once I had really deleted a very important piece of information, I was really worried about what is going to happen. So the good thing is that you can see a version history. So example, like, for example, if Dr. Lipi would have had done something in this, and I have deleted it. So it clearly shows what changes. So you have to tick in this box, show changes, and we can clearly see who made, for example, if I've deleted something, it clearly shows that I've deleted that, and hopefully I can, get back to it. So that way, that's really cool. Next thing is, in the file, we're done with it, right? In edit, I think, again, it's the same undo. Paste without formatting. Okay, then view. So this, I think, self-explanatory. Insert, again, we can insert an image. We can insert a table, a drawing, I think emojis and whatnot. And right. So in formatting, again, it's similar to how we use a Word or a PowerPoint, really. Like everything is very, I'm sure every one of us knows this aspect of it, hopefully. And it's like we can always experiment because everything is going to be saved. And even if you lose any important piece of information, it is always there in the version, like the history. So you can always experiment. And then right, so you can align it, you can put the columns, the bullets, the page numbers, page orientation. Okay, so now coming to the tools, like you can also get your spelling and grammar checked if you want that too, and word count, review suggested edits. And I think this is the most coolest feature of Google Documents. That is, firstly, is translate the document. So I can literally translate the document to any language that I want to. So I can choose a language. I'll choose Arabic. Right. Translate. So here it is. I'm not very proficient in Arabic, but I'm sure it has done a good job. Next thing is the tools. the feature of voice typing. Okay, so this is really cool. So I can click on this, and so the thing is, actually, one second, I have to change it to my so I'll choose English and India. Okay. So the moment I press the red button, it is going to start recording whatever I'm going to say, and hopefully you're getting a clear idea about what I'm trying to demonstrate. Full stop. So if there's anything regarding the voice typing that you want to know, there is the help icon wherein you can go for the help, press the help thing, and so it usually shows you all the options, and over there you can search for voice typing, and it gives you exactly what you need to do. I think it's taking a lot of time to load. So just so I think I'll just work on this by the time it loads over here. I'm going to, so the next thing that I'm going to do is I can, again, the same features that we use in a Word or, PowerPoint, we can change the color of the text. I mean, that's a very disgusting color, so this is good. We can use this, and we can change whether we want to bold it or not. We can bold it, we can underline it. And I want my team leader to be able to fill all the gaps. So I can do that. And yeah, there's a keyboard shortcuts over here. You can definitely use those. So I'm not very proficient in them, but hopefully you can, go through them once you're free. And so let's look at this. It's still loading. So, right. So I'm going to go back to the document. I think there's one more thing about page where we can actually change even the color of the page orientation. So in page orientation, you can want it to be portrait. Okay, so there's a way whereby I can actually even fill in colors in that. And all right, so I hope I've just covered whatever I could give you, my 2 cents on Google Documents. And if you have any further questions, please let us know. And Dr. Nadir, if you can add to whatever I've just said, that would be really great. So.
Thank you, Dr. Asna. This is great. So if you go to the Arabic version, can you share again?
Sorry, sir. Yes.
Can you go to the tab where it was in Arabic? Yeah. So basically, if this is, for example, the team member started a project about writing an abstract, and these are the items for that abstract. So let's say the first one is the introduction. So we're gonna assign the introduction to, I'm gonna just pick up names here. For example, Dr. Sahar, she will be assigned to work on the introduction. So what Dr. Asna will do is she's gonna hit share and then add Dr. Sahar email, and in the text or the instructions, she will tell her, can you, for example, complete this introduction or edit, and so forth. What we can do now, if you can, Dr. Asna, hit share.
Yes, sir.
And then on the left lower part, hit restricted, and here you can add anyone with the link. They can edit and copy the link here, copy the link below. So I'm gonna ask you to share that in the chat.
All right.
I'll say done, or yeah. So now every one of you in this Zoom meeting now, if you have Google account, if you hit on that shared link Dr. Asna was just sharing with you, you will get into that document, the same document that we are sharing now. And now we have everyone can add their names and add any comments. If you look at, can you hit done, Dr. Asna? And on the top there, we have at least 3, 4, 6, 7 people, 8 people. They have access to this document. Here are the list of the anemone. So they didn't put their names, but they can. Total of 13 viewers. So any of these 13 or 14 fellows, they can comment, or they can edit, or they can add, or delete, or whatever they can do in this document. So this is how you share the document and then work together on that document. So let's say we are going to write an abstract and submit it tonight. So for me, I'm gonna start dividing the task or the items in that abstract. So the first section will be the introduction. So I'm gonna ask Dr. Haifa, Dr. Abdullah, can you work on the introduction part? And then Dr. Asna, Dr. Sahar, can you work on the body? And whoever next, they can work on the conclusion, for example. And by the end of the day, all of us will finish the task or the poster or the abstract in a timely fashion, and we can submit it tonight if the deadline is tonight, for example. This is how the contribution or collaboration can happen. The other way to do it is some of you here in the US and some of you in other countries, some of you in India, in Pakistan, in Africa. So what happened is it's 3 o'clock in the afternoon here, while it's night time in other countries. So I can work with my team in the US here, and by the time night happen here, then I can transfer or I can email, share the document with the people in India or Pakistan where it's early morning there. They can work on the document. So we can use the time zone difference, take advantage of that, if that makes sense.
Yes, sir.
Okay.
Thank you so much.
You're welcome. Any questions? Thank you so much, Dr. Asna, for great presentation and demonstration.
Thank you.
And this can be done for every type of document in Google. For example, you can create a sheet, Google Sheet document like Excel file, and you can share that with a group, with a team. You can do it with Google Slides, like the PowerPoint slide, and then you can give access to that Google document for the other fellows to comments or maybe edit and make changes. So this can be done, like for example, the presentation from Dr. Ali today, he sent me a document. I changed that to Google Sheet, Google Slide, and I can share that slide with you. So I'm gonna share the screen. I'm gonna be the host again. So if I share this is a document Dr. Ali was presenting today, and then I'm gonna do the same, share, and then click anyone can copy the link, and I'm gonna share it with you guys. Gonna stop share in the chat, for example. And any one of you can also get into that document and, for example, they can comment, they can change the colors, they can add more information up to date, for example. These are the people now, they are able to comment or edit this document, if that makes sense. And any one of them can present that document. Let's say I have trouble communicating or sharing the screen, or my laptop battery is dead or whatever, I have bad signal, then Dr. Samahir can have access and she can present or can open the file and go over the slides while I'm talking or presenting voice over there, if that's the case, like the way we did with Dr. Ali today, for example, if that makes sense. Any questions? Dr. Ali, any comments, any questions? If none, we can go to the next topic. Thank you so much, Dr. Asna, for great presentation.
Thank you, Dr. Asna. The presentation was really amazing. Next speaker is Dr. Ali Awad. He'll be presenting on the presentation skills and using Canva.
Thank you, Dr. Podel. Thank you, Dr. Nader. I hope to have the host privileges to share my screen.
Just give me a second.
Yeah, absolutely.
Can you try it again?
Okay. And hopefully you can see my screen right now. Okay. So I'm Ali Awad from Forest Green 1 team, and I'll be talking to you today about the presentation skills that would impress, engage, and inspire your audience. This is to remind you, please, to turn off your microphones during the presentation. Feeling free to type any questions you have in the chat box, and I'll be happily addressing them in the after completing my presentation. So the learning checklist for this presentation is, we're going to talk about the presentation as part of communication, or as a method of communication, the core concept of good presentation and good communication in general, virtual versus face-to-face presentation, distractions management, why virtual presentation skills are important in this day and age, what makes an excellent online presenter, and some bonus tips and tricks for virtual presentations. So a little bit about myself. I'm Ali Abdul Karim, as I mentioned. I'm an IMG from Sudan. I've graduated from University of Khartoum, class 2022. I'm currently residing in Muscat, Oman, and have little interest in, or actually some interest in data science, machine learning, both statistical concepts and programming, especially in their applications in medicine. So presentation as a method or type of communication. If I want to relay some information or knowledge to someone or to a group of people, I can just talk to them. I can send them a message. I can email them, or I can make a presentation. in a meeting, be it face-to-face presentation or a virtual presentation. So why presentations in general are very important? If you're trying to convey or trying to summarize your results or what you've reached in terms of knowledge from your project or from your research, you will most likely use presentation, be it face-to-face or virtual. So hence, getting skills, good skills in presentation will make you a good communicator and will make sense of your project. Because you're for example, in this fellowship, we're making research, but in order to share the results of these researches, we have to effectively communicate the results through presentations, like oral presentations, poster presentations, or maybe sometimes virtual presentations. So, as I say, presentation is type of communication, and thus this means that presentations inherit the characteristics of communication. We all know that there are verbal skills in communication and non-verbal skills in communication. Verbal skills, for example, in communication would be talking clearly and precisely and have a clear voice, using body language. Actually, body language is non-verbal, but for the verbal skills in communication, these will also be applied to your presentation skills, because presentation, as I said, is a part of or is a type of communication. For non-verbal skills, that would be using body language, maintaining eye contact with your audience, and such. These will also be applied to your presentations and will be considered as good presentation skills. So what is the core concept of a good presentation? As I said, presentation is a type, many times said, presentation is a type of communication. And communication, I would like to imagine communication as a thread through which that you will convey your knowledge or receive knowledge from others. So in order to convey your knowledge through presentation, you need first to establish this thread. I call it the thread of attention, because when you have the attention of your audience at that moment or at that setting, you can convey your knowledge and your audience will be able to receive what you're saying. So establishing the thread of attention. Now, how can I establish the thread of attention? First of all, by stating what are you going to talk about, the title of your presentation. And secondly, stating who you are. This will break the ice between you and your audience. You will familiarize your audience with yourself. Talking a little bit about yourself is a very good point and a very good element in establishing this thread of attention. Also outlining your presentation points that you will be talking about is also a good establisher of this thread. After establishing this thread of attention, you will need to maintain the integrity of this thread. And by maintaining the way that you can maintain this thread can be summarized in one word, that is minimizing distractions. We will talk about distractions in the following slides, but minimizing distractions is the main job you have to do throughout your presentation to maintain this thread of attention. And finally, you have to safely remove this thread of attention, just like you will be connecting to your internet modem or connecting a flash drive. You have to safely remove it. And safely removing it by summarizing your key concepts or key takeaways from this presentation, what you should be what you should have learned from this presentation at minimum, and such. So virtual presentations versus face-to-face presentations. they're very similar in terms of the skills that needed for both of them, yet there's some kind of differences between virtual and face-to-face presentations. So they both require some sort of preparations. If you want to make any sort of presentation, you have to be prepared, preparing your slides, preparing yourself, your ideas, what you will be saying, understand the concept of the topic, the concepts of the topic you're trying to convey through presentation, dress appropriately, using slideshows, as I mentioned, trying to use any visual or audio aids through slide presentations. I mean, like adding videos, audios, or any sort of, like we've seen a while ago, live demonstration of Google Documents. These are all visual aids that will help you to convey the information or the knowledge you're trying to teach more precisely and concisely. Managing distractions and managing audience is also a shared part in both the face-to-face presentation and the virtual presentation. So these are all similarities, but what is the main difference between virtual and face-to-face presentations? Also, it can be summarized in one word, that is distraction. There are more distractions with virtual presentations than with face-to-face presentations. So distractions in general, be it face-to-face or virtual, can be categorized into technical distractions and non-technical distractions. By technical distractions, I mean issues with your laptop, issues with the projector, issues with the microphones, or maybe bad internet connections. These are all technical issues that you should be or that you should have a plan to troubleshoot before your presentation, and maybe during your presentation if anything unpredicted happened. Other technical issues can be also troubleshooted if you're willing to ask for help from any of your colleagues that is more familiar with the technology. That would be a great idea to troubleshoot or address these issues beforehand, before the presentation. So the non-technical issues would be dressing inappropriately. That would be a huge distraction, especially if you're opening the camera or you're in a face-to-face presentation. Speaking not so much, you're not so much confident in your speak or your points. That will show up, unfortunately. People will pick that, or perceive that, and it'll be some sort of distraction. The non-technical part or non-technical distractions can be troubleshooted by practicing beforehand, before the presentation, making rehearsing with your friends, colleague. That will minimize these type of distractions, and also paying attention to your general look, your outfit, and noise, your environment, your background, and such. All right. So why virtual presentation skills matter? As we've all seen during the COVID-19 pandemic, the companies and the world come to the reality that remote jobs and remote working is a skill that need to be taught, learned, and addressed, because we're not in security or in safe zone from getting another pandemic, or getting some other problem that will make us not going to work physically. So that showed clearly during the COVID-19 pandemic. Also, if you want to increase your reach out, for example, this fellowship this tele fellowship, I'm now speaking to people that are scattered throughout different countries. This couldn't be happening without virtual presentation. So if you want to increase your reach out, increase your knowledge, receiving knowledge, or conveying your knowledge or your results, you have to use virtual presentation, and thus having these skills is very important. So what are these virtual presentation skills? I've mentioned some of them earlier. These are same skills with face-to-face presentations, but some of these skills should be paid more attention to it. We have to pay more attention to some sort of skills. Why? Because, as I say, there are more distractions in virtual settings than the face-to-face settings. And it is actually harder to grasp or grab the attention of your audience through just cameras and microphones. It is harder, but it is manageable. So these are some of the skills that is nice to have in your virtual presentation, like dialing in before the meeting start. This will decrease your level of stress and anxiety. Preparing the technology, as I mentioned, to mitigate any interruptions or distractions. Dressing appropriately. Professional surrounding and background to eliminate you won't be eliminating noise 100%, but to minimize such distractions. Managing your audience by including a slide like I've included earlier, the housekeeping rules, by reminding your audience to turn off their microphones, that you will be receiving their questions and addressing them after the end of presentation. These are all good steps to minimize the distractions during your presentation. And also developing an outline for your presentation, manage the expectations that your audience will be having from your presentation, and sometimes, or actually making them more tolerant of the time that your presentation will take, and more have an estimate of your time that you will take. I'd like also to mention here, you can see my screen, I'm not sure. Okay, that I'm including the number of slides. This is actually and also a good strategy to manage the expectation and decrease the boredom that might result from such virtual presentations. There are some additional skills that are nice to have, like maintaining eye contact with the camera. This will somewhat create a like of a face-to-face experience, maintaining an eye contact with the camera, as I'm trying to make in this presentation. Preparing and knowing your slides will make you more comfortable, and pacing your talk will be easier through knowing your slides. Practicing, as I mentioned, keeping everyone engaged. Unfortunately, this topic would not make a good example of engaging your audience, but the previous presentation made by my colleague here, as she demonstrated the Google documents, that was a very good example of engaging your audience by live demonstration, by asking questions, and so forth. Being enthusiastic with your topic. Again, this can be gained by knowing the basic concepts of your topic, being comfortable with your topic. Early preparation will make you speaking enthusiastically about your topic. I remember this online course that has really good to perfect content, but the main problem was that the presenter wasn't so much enthusiastic about the topic, and it shows. People perceive that easily, and that decreased the overall experience and the rating of the course, unfortunately. So you have to pay attention to your enthusiasm, your body language as well. Some people might think that paying attention to your body language through virtual presentation is not that much of an importance, but that is not completely true. It's the contrary. You have to pay attention to your body language because it will attract more attention. Be precise and pay attention to the time. Taking so much time will, if I can relate to the analogy I've made earlier about the thread of attention, I said establishing the thread, and I've talked about how to establish that, and maintaining the thread, as I said, by minimizing distractions. So if you, when you pay attention to your time and be precise and concise, you will maintain the integrity of this thread, because this thread is time limited. Whenever you're increasing the time, whenever you're repeating points, this will unfortunately will result in cutting this thread, and people, you will lose your audience. And if you started losing your audience attention, it is very hard to gain that back. Letting someone else to help you, checking the chat, and more importantly, and the last advice is to be yourself. Just be yourself, feel confident, don't be too much stressed. It doesn't have to be a perfect presentation. You will learn. We are all learning. You will learn through the years and through making enough presentations. I remember this one professor that making or educating about a kind of sophisticated course in programming, I remember. And I was wondering, why is he so good about teaching this course? And then he mentioned that this is his 9th time. He has been teaching the same course for 9 consecutive years. That's why he's so good with teaching it. So practice, 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 and with experience, and hopefully with experience and the coming days and coming years, actually, you will be better in your presentation skills. So I've mentioned that to pay extra attention to your camera and to your audio setups. But if you're trying or starting to invest in your setup in general, you're new to this virtual presentation realm, it is wiser to invest in your audio setup first, because it's, first of all, it's cheaper, and it is more important in the overall experience of the virtual presentation. A bad video feedback in your presentation might affect your presentation a little bit, but it won't be a big problem. It won't cut the thread of attention. But a bad audio will definitely cut this thread of attention. It will be a very bad experience, and people might start leave your meeting. So an audio setup, and I can mention some of the educational series that only use audio setup or audio feedback, and they don't even have video feedback, like Boards and Beyond, like Dirty Medicine YouTube channel, and Pathoma. They don't even use video feedback. They only use audio setup and PowerPoint presentation, of course, plus the very good content. That will make you go to a lot of reach far goals. So extra tips and tricks for your presentations. So presenting is not just reading your notes. It's more than that. It's about delivering. It's more of a performance than just reading or reading slides or notes. So it's about engaging and inspiring your audience through the previous skills that I've mentioned, and some extra tips I'd like to mention here as well. These are preferable add-ons. So as I mentioned, understanding your topic beforehand is an essential skill that will make you more confident in your presentation. Yes, using presenter view in PowerPoint. So I've seen that a lot of people might be using the presentation view. This is the full screen view, but more preferable to use the I can share the screen after I'm done with the presentation. The presenter view will give you more control over your presentation. You will have notes. You will see the coming slide. You will see all the slides in the bottom. You will have more control in your virtual presentation. So the presenter view is preferable than the full screen or the presentation view. I'm not sure what it's called. The full screen or the presentation view. Yeah, I'd like also to mention that knowing the shortcuts of your platform, for example, the Zoom platform, if you know the shortcuts, it will make your life very absolutely easier in terms of virtual presentations. Knowing the shortcut for turning on and off your audio feedback or your video feedback or how to share your screen, knowing all these shortcuts will make your life very easy, and you won't be searching in your screen for where I can toggle on or off my audio or my video, where can I share my screen. It will happen fastly and make you focus on the more important aspects. Of course, creating backup for your presentation is very important, as some of my colleagues earlier sent to Dr. Nader a copy of their presentation. This is a very good practice. Plugging your laptop to a power outlet and plugging it to directly through a wire to your modem, to your internet modem, is also considered a good practice because you will have more stable internet connection in virtual setting, of course. You will have more stable connection than Wi-Fi. It's also better to use your laptop than your smartphones. You will have more flexibility using your laptop. As I mentioned, that you will be using shortcuts. You will have extra screen real estate. It's a more fun experience and it's an easier experience to use your laptop than your phone. And lastly, you have to consider your pace with the presentation. If you're going too fast, the main goal of your presentation will not be met. That is relaying the knowledge to your audience. If you're going too fast, your audience might not hear or interpret what you're trying to say, what you're trying to convey. And if you're going too slow, you might, as I mentioned, lose their attention altogether. It is a good practice, as I mentioned, I believe I mentioned earlier, to mix up your content, your slide content, with graphs, with videos, with GIFs, and so forth. This will make a more attractive presentation, moving parts in general, moving parts in your slides and in your video feedback. If you're sitting through all of your presentations without moving, without doing anything, you might as well turn off your camera, because this will be in a negative point in your grasping your audience attention. So having moving parts will attract the attention of your audience. Yeah, so the key takeaways from this presentation is As I mentioned, presentations are a type of communication. Establishing, maintaining, and safely removing the attention thread is the core concept of a good presentation and good communications in general. Having a plan to deal with the distractions beforehand is a very good practice and will make this whole experience of presenting more fun and easy. Gaining the essential virtual presentation skills and familiarizing yourself with the technology that is used to deliver such presentations is also a sought after skills, especially in this day and age after COVID-19. And finally, you have to summarize your presentation key points and to make sure that people followed along all your slides and your flow of ideas, so that you can start receiving questions, answering them effectively, hopefully, and maybe brainstorming new ideas emerge from your presentation. As a last saying, it's not only what you say, but how you deliver it. Thank you, and I'm happy to receive any questions, any add-ons, comments. Thank you very much.
Thank you so much, Dr. Omer, and this excellent presentation and about the presentation. Thank you. Any questions or comments? So I'm gonna follow up with Dr. Omer, and I'm gonna ask you, you have the link for the slide that we were just talking about, the I think the first one. If you have access to this one, I'm gonna ask one of you or any one of you, can you show me how can we add slide number to this slide presentation? Maybe one can try that. Maybe Dr. Ali, if you want to help us as well. So I think you can go to insert, and at the bottom, the slide number, you can hit that and it will ask you, you want to add the slide numbers on. The first slide will be the title, so you want to skip that, or if you want to start from beginning, you can apply that to all of them. So this is how you do it. If you notice, this file is PowerPoint, so Dr. Ali sent it as a PowerPoint file. So in Google Slides, you cannot do the slides number, so you have to convert or save as Google Slides, and then you can add the and then you can insert the numbers. So if you say yes here, you can apply and it will show up somewhere here. Okay, let's see. Here we go. So here you can see the slide number. So this is slide number 5, slide number 6, slide number 7, and so forth. Any questions about the presentation to Dr. Ali, or any questions, comments to any of the presenters from today's?
Yes, Dr. Nader.
Yes, go ahead, Dr. Salma.
Thank you for all the presenters. My question is regarding the Google documents. If there is a way so we can convert the document directly into Word or even a PDF.
Yes.
Yeah,
So,
if you could share with us a shortcut. Thank you.
you're welcome, no problem. So I'm gonna give me a second. So I'm gonna go here. Let's start a new document. So if you type doc s.new, this will start a new document. Let's say demonstration. So if you want to save this, for example, this is the list. And then you want to add the names here. After you added the name, you want to print that or you want to save them as a PDF. So if you click on File, Download, PDF format, it will save that as a PDF format file. If you want it only plain text and you want to send it in your email, or you want others to edit their names, for example, you can save it as just pure text or plain text. You can save it as Word document, and you can share that as well.
Okay, great. Thank you, Doctor.
You're welcome. Thanks. Good question. Any other questions? If not, we can go to the last topic, which is the updates. Usually at the end of the meeting, we will have a couple of minutes for any project updates or new ideas for new projects.
I have a question to Dr. Ali. Thank you, Dr. Nader, and thank you very much to all the presenters. I'm just wondering, I would like to ask Dr. Ali, which application did he use to create the presentation? It just caught my attention from the beginning. And I believe it's not PowerPoint, just I'm wondering which application, if that's possible. And thank you very much.
I assume that you're talking about my presentation, hopefully. Yes, I've downloaded the PowerPoint from Canva. These are templates, and I've actually missed to mention that you should probably use templates or pre-made templates that will make your preparation time lesser. You will need far lesser efforts to prepare your presentations by using templates. I've downloaded it from Canva and then tweaked some slides and added my notes. Thank you.
Thank you, Dr. Ali, for sharing. So Canva is very useful tool for presentation, and they have an artificial intelligence. So you can even add some question, and they can create the slides for you or generate the content, and then you can tweak them. And Dr. Haifa, go ahead.
Yes, thank you everybody for the great presentation and the great tips, and thank you for you, Dr. Nader. Just my question, like about like if I want to do research and I found like most of the study, I found it's like about they are still, like the study are still like in experimental, like still there. Like I found it in mice, and like, is it okay if I include it in my research, or do I have like, if I want to do research, that it should be like it's already applied, or like they're, like don't know if you get my question or not.
Dr. Nadir, your microphone is muted. We cannot hear you.
Yes.
Thank you so much. So it depends actually, and this is a good question, and it depends on what you want to write. So if you want to, let's say, write an abstract using a systematic approach, like systematic review of some studies and so forth, it depends on inclusion criteria, exclusion criteria, what you want to do with the data that you obtained. Most of the time, animal studies might not help you. But if you are writing about pathophysiology of something and you want to use this experiment to highlight some mechanism that can be used as reference for you, something like that. So it depends on what you want to use it for. Certain medications may have side effects in animals and so forth. So you want to mention this is a new medication and we are going to use it, and these are the common side effects, what you found in the literature, something like that. Thank you.
Thank you, Dr. Nader. Thank you.
Go ahead, Dr. Sabri. Dr. Sabri, you have a question or comment?
Yeah, thank you. I was muted, Dr. Nadir. Thank you so much. So I am proceeding with my project that I have started before joining the Telegeriatric Research Fellowship, which is regarding a cardiology topic, and I'm planning to submit it to the American Heart Association by the end of May, I guess, because the deadline until 6 June. But I don't think so that I could attend the meeting. So I would like to give me an advice or a suggestion for this issue.
That's a
Thank
good
you.
question. Thank you so much for the update. So it's a good thing that you are approaching that conference. It's a good one. So if you are finishing your project and you are going to present it in a format of abstract or poster or oral presentation, what in the past, what did we do? We asked some of the fellows in the area or near the area, where is the conference will be, you know?
Yeah, it will be held in Chicago.
So if there are some fellows in or around Chicago area, then we will include one of them who might be free during that time so that they can join or go and present in person. If that's required. If it's not required, you can submit your work virtually, and sometimes they accept video. So you can record your poster in a video format and then submit it. Is it required to be in person?
Yeah, they said you have to attend the meeting in order to your upcoming project to be accepted.
So
unless you
that,
have it, yeah.
Yeah, in that case, in your team, if there is anyone in or around Illinois area or the state of Illinois, they can go to Chicago, or if anyone in the states who is available to go and present, then it will be the cost of the hotel or cost of travel and the registration, and that will be the approach used by the fellows in the past. So usually they will see whoever is near that city, and then they can help cover the cost together, if that makes sense.
Yeah, thank you very much.
Where are you located? Where are you now?
I'm currently in Riyadh, Saudi Arabia.
Saudi Arabia, yeah. So I would see if in your team you have someone in the US, and if they are available to travel during the period of the conference, and they can present that poster.
Yeah, thank you so much for your feedback.
You're welcome. Thank you. Dr. Myra, go ahead.
How are you, Dr. Nadir? How are you, team? My name is Mayra. I'm back, Dr. Nadir, for the conference for the APA, American Psychiatry Association. It was wonderful. Thank you for giving me the letter and I was able to assist. For anybody interested in the APA or in psychiatry, they create a membership especially for international medical graduates certified, and we are able to join the association free. It was really good. Yes, we did a caucus, a meeting with all the IMGs that we were there, and we fight for that right to be able to join the association. The other thing I wanted to let you know, guys, I just received your email, Dr. Nadir, and I send invitations to the Lime group to anybody that is going to be with me in this new cycle. This is just, if anybody's here from the Lime group, just check your email and I send you a wonderful email that inviting you to join the WhatsApp group, and we'll buy phone number and email. Says, well, that's it. Thank you, Dr. Nadir. Have a wonderful afternoon, okay?
Okay, thank you so much, Dr. Myra, for sharing. And how did the wedding go that last time?
Oh yeah, it went wonderful. Thank you.
Have a
Thank
good
you
one.
so
Thank you.
much.
Anything? Thank you so much, Dr. Myra, for sharing. And for those who are interested in psych or are planning to apply for psych residency positions, I think it's a good idea to get into contact with Dr. Myra and get more information about how to join the APA and be part of this wonderful group. And I think you can make connection. It's gonna help you a lot. So
It was wonderful. Yeah, the conference was like breathtaking. They were like 10,000 psychiatrists, doctor there, and it is important, guys, to publish as much as we can, because that's what is gonna put us ahead of American, like medical students and Americans. We have to publish as much as we can. Like that's what. If you guys have any interest in psychiatry or anything related with psychiatry, like text me, write me, or yeah, contact me.
sounds good. And remind me, present? Did you present a poster or?
No, I didn't, Dr. Nadir. I was going to, but at the end I didn't got on the time, but I couldn't. But next one, next one I'm preparing for it.
No, if you have any poster ready, maybe you can present to the group.
I do. We're working in the poster for the Alzheimer's and the confabulation. Yes, I do. I think that one, because the other one is too related to neurology, and I cannot use it in the psychiatry. But the other one, yes, I could.
Sounds good. Thank you so much.
Perfect. Thank you.
You're welcome. All right, Dr. Randa, go ahead.
Assalamu alaikum, Dr. Nadir.
Alaikum salam.
Assalamu alaikum, everyone. First, thank you, Dr. Nadir, for this great opportunity. And also, thank you, Doctor, for this informative and interesting topics you presented today. First, I want to introduce myself again. My name is Dr. Renda Hassan. I am a new fellow in this program, graduated from Kordofan University in Sudan, and currently I'm living in USA. I completed step 1 and step 2, and hopefully planning to apply for upcoming residency program 2025. Allah. Actually, me and some of my colleagues, also a new fellows, we thought to create a mobile app to help diabetic patients to regulate their sugar and cholesterol contents in their diet. That at the beginning. And the idea came after we joined this program, and we saw a wonderful team who dedicated and created an amazing mobile app for patients with kidney disease. So first I shared my idea with my colleague, and then also they show their interest on this project. That encouraged me more, and I reached out to that team, and Dr. Amel expressed her interest in this project, but she's a little bit busy right now, but will join us soon. And also she advised us to start and to make a clear plan right now. And she provided us with the link, which will help us to know how we can create the application. So we want your permission, if that's okay, Dr. Nader, or if you have any advice or suggestions, would be highly appreciated. Thank you, Dr. Nader.
Thank you, Dr. Randa. This is great idea. So it's good that you already started the steps, so you know how to. So it's just a matter of creating your team, dividing the task, and know how to proceed. So I give you the green light to go ahead. And also for any other fellows who, any one of you guys interested in developing an app, if you have ideas, we can share together. And some of you might have some technical abilities, some of you might have some knowledge of how to, some might have some skills, and some might have ideas. So we can collaborate and create teams to develop similar mobile app to the one that we shared in the past. So go ahead, Dr. Randa, and your team, and let me know how we can help you if there is anything that we can do together. But yes, go ahead. Thank you for sharing.
Thank you so much, Dr. Nadir. And we actually not have experience on this. So we want, if there is any senior in this program who can join us to help also Dr. Amel, to make her aware of it. Yeah.
If you want to get in touch with Dr. Mafaz, she is also Mafaz.
Okay. Okay.
Sorry.
Okay, I will try to reach out to her. Okay. And also, yes, I want to know what's the maximum number of fellows can participate in this project, because I saw a lot of fellows, they are interested. So we can make a plan from them.
Yeah, so the easiest answer to this is for the mobile application, we don't have a limitation for the fellow. So you can accept as in your team. And the question will be, we want everyone to participate. It's not just to put their names. So the trick is to identify tasks and involve everyone in certain tasks. Anyone can get one task or more than one task. So the development of the app itself might be divided into small tasks and divide these tasks between the fellows, or the post publication task. Like if you want to start from now, getting some fellows in your team, you can see which one has which area interest, like if they have the knowledge or the skills, or they want to do this and that, you can get them involved. And some might be interested but are busy and they don't know the skills, or they don't have the skills, or they don't know the knowledge for contribution. So for these fellows, maybe the idea is to get them involved in distributing the idea that the app will be available in the Google Store. We want you to test it and see if you have any comments that we can improve in the next version, and so forth. So There is no limitation, the short answer for your question. Thank you.
Okay, thank you so much. We will do that. Thank you.
Thank you for sharing and good luck.
Thank you so much, Dr. Nadir.
Thank you. Any other ideas or any other updates or questions, comments?
Yeah, Dr. Nader, actually, I just remember that also I have one of my paper that is just got accepted in combined otolaryngology meeting, and it will be presented the next week, 15th of May, and I just wanted to share that with you.
Excellent, congratulations. That's great. So
yeah, thank you very much.
You're welcome, thanks. And if you have the linked webpage, you can add that to your home as well, just to share with the fellows there. But thank you.
All right, thank you so much.
I have one question for you, I think.
Right, sure.
Are you going to present in a conference or it's another fellow?
No, it is not in the team, basically. These two projects I was working since, I think, September of 2023. And we just completed the first one, which will be presented the next week. And the cardiology topic will be hopefully will be submitted to American Heart Association. But he's not with us in this program.
Okay, no problem. Thank you so much. Yeah, thanks for sharing.
Thank you.
You're welcome. Any other questions? Any other comments? Go ahead, Dr. Nada.
Hi, Dr. Nader. How are you doing?
Very good. How are you today?
I'm doing well, thank you. I just wanted to share that I was thinking about doing like a new WhatsApp group for diagnostic radiology. Anybody who's planning on applying to it for 2025, since I've noticed there are very few members who are interested in it. So I thought if everybody that was, going to apply to it, interested in it, we all thought together, it would be easier to come up with new research questions and help each other during the application process itself.
Sounds good.
Sounds good. So if anybody who's interested, please let me know. You can contact me and I would be as well doing it on the WhatsApp group that we have together. I will be sharing the link there. So I'm looking forward to working with everyone. Thank you.
And if you can also share that in the big WhatsApp group for the fellowship, the seniors might also distribute that to the other fellows.
Sounds good. I will do that. Thank you, Dr. Nader.
Thank you. Go ahead, Dr. Sarah.
Good evening, everyone. Dr. Nader, thank you again for this opportunity. Me and my colleagues actually made an internal medicine subgroup for everyone who's interested. We came upon a problem. Some of our ideas require ethical committee approval. And yeah, so since we're all here today, or most of us are here, if anyone knows the Sudanese Ethical Committee, if you could just share their details or whatever, how we can actually reach them so that we can get things started, since we are actually really, really interested. And I mean, it's already May and we are running behind, a bit late.
Can you elaborate a little bit about your research idea and the method, please?
Okay, so basically, the main author of some of the ideas is Dr. Awab. I don't know if he's here. Dr. Awab, are you here? Yes, Awab. If you could just share your idea with them, that would be great. Okay, never mind. So basically, it's questionnaire based. Let me just get into the group. we have more than 3 or 4 ideas so far, but some of them actually require ethical approval. And I think Dr. Awab already contacted you, Dr. Nadir, asking, yeah. So one of them is the one I'm scrolling back. People have been very talkative in the group, and it's taking a while for me to get back.
That's all right. So basically, if the research idea that you are going to obtain data from humans, yes, you will need the IRB approval. If it's only one case, you want to summarize that and present it as a case presentation, you don't need an IRB approval. Sometimes it's clear cut, sometimes it's not clear, so you can apply for IRB approval and expedite. So they will say, yeah, there is no risk and there is no involvement. You are approved faster than the short and the long one, the detailed one. The other question I have is, or the comment I have is, I used to be with MSU. We used to have the IRB from MSU, Michigan State, and also from the hospital. So if we want to get same data from patients, patient records and so forth, IRB will get in touch with the IRB from the Sparrow Hospital, and it's easier that way. But currently I'm out of MSU. I don't have the connection with IRB, but we can get some of the attending in the future in collaboration with some here in Michigan, or if your team is involved, some of the fellows in other institutions here in the US, one of the team members can approach the IRB in that institution, and then we can move on with the process. I know it's, you said end of May or June, and you want to submit, so.
Okay, so if the questionnaire is actually supposed to be distributed among medical students or doctors, do we still need ethical approval?
Yes, I think you will need some form of that, yes.
Okay.
As long as you are going to publish it, and if it's, let's say, for quality improvement and you want their comments of how we are doing and how we can improve, you don't need approval. But if you are going to obtain some of their information and then publish this data, then you need the approval. Thank you.
Okay, yeah, I got the idea. Thank you, Dr. Nadir.
Thank you. Any other questions or any other comments, suggestions, ideas?
Yeah, Dr. Nadir, actually, I have one more comment. So I have made my WhatsApp group for Indigo One team, and I sent the email and the link of the WhatsApp group to all of the members. So I think there is 5 to 6. They are still didn't join the group. So kindly, guys, if you can review your email and join us in the group, because we are planning to have a team meeting in the next couple of days. Thank you.
Thank you, Dr. Sabri. And I just want to make sure some of the fellows joined the fellowship program, some of them in Sudan, and they might have some technical issues with the war going on, and a few also from Palestine or Palestine. So I'm sure there are trouble with internet and access and security issues. So if you have some of these fellows in the team, they may not be able to respond back to you in time. So I just want you to be give them some time in the future. Maybe they will be able to.
All right, totally. That's totally fine.
Thank you. I'd like to thank Dr. Libby, Dr. Samahir, and your team, all the presenters from today. Thank you so much for helping us and presenting great presentations, good topics. Thank you all the attendees from today's meeting and those who will come to watch the recording later. Thank you and a wonderful day. Have a wonderful night wherever you are, and we'll see you next week, inshallah. Assalamu alaikum.
Thank you, Dr. Nader and the team. Thank you.
Thank you, Dr. Nader.
Bye.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Have a good day. Bye.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Thanks, everyone.